Thank you. So Samia talked about the importance of adding in QI to your work, and every time somebody says, oh, I have this idea, she'll say, great, that's a great QI project. So hopefully today's talk is going to be really practical to understand how to develop a QI project using the model for improvement method, and then learning how and when to use very specific tools to conduct the project. And these are the tools that we'll talk through today. So when you're using the model for improvement model to do QI, it really starts with asking some basic questions. So the first question is, what do we want to accomplish? I want to do a QI project. What do I want to accomplish? So what is my aim? What am I trying to improve within my system? And then how will we know if a change is an improvement? What are we going to measure? What data are we going to use? And how are we going to get it? What change can we make that will result in an improvement? So what are you going to try? And the idea is to test small changes before you make it permanent. You try it, you test it in a small environment, and you decide if it works or it doesn't work, or if you're going to change it and how you're going to do, and you continue to do these PDSA cycles. So when in the model of improvement, there are sort of phases to a QI project. So there's sort of the planning phase here, where we're trying to understand our current state. Where are we starting from? And then break things down and break down the problems so that we can make improvements. And then we move on to sort of defining our measures and setting our goals, developing our theory of how we're going to improve, what things we're going to change, and then design and test those changes, and implement and standardize the things that work for sustainability. So it's really important that these things are sustained and they become your standard of care once they do work. So the project pathway starts from organizing your people and your plans, and then understanding what happens in this process of care now. So we need to visualize our process, talk to the people who have experience with it, identify what could be better, make note of things that don't happen like they should, learn why these problems happen, know which problems happen most. These are probably the ones you want to really work on attacking. And then how are we going to define success? How are we going to set our aims, decide what measures are going to be show significant improvement for us? And then we need to consider what changes we can actually make and prioritize things, try something new, do something differently, use these cycles to keep improving, and then determine what we're going to do. Is it working? Are we keeping it? If it's not making a difference, are we stopping it? And then make those successful ideas part of our everyday activity. So you start out with basically saying, who is my team? Let's list who's the leader, is there a sponsor or an advisor, who are just the team members, are we going to include a patient or family member, and then what are their levels of commitment and communication needs going to be. So lining that up and spelling it out at the beginning can be really helpful to being successful in moving forward. Your expectations are set for everybody. And then the next thing that you really want to think about is creating what's called a high-level process map. So this is learning about your process, sort of walking through it, trying to really in a high-level way say what do we do here? And then when we do that, we make a first draft, we talk about it, we go through it again until we come to a consensus on what we're going to do. So here's an example. This is the setting of wanting to improve any process that you want to say. This one happens to be improving mental health screening in a CF center. So this was an example of an adult center that wanted to improve the rate of mental health screening, and this is their high-level process map. So they take people who they have to determine eligibility, and then they say person with CF is offered the screening is completed, it's reviewed, the results are discussed, and they're tracked and documented. That's the high level. And having a high-level process map that's like 5 to 7 steps is going to be really helpful moving forward as you go into your next steps. But you may also, over time, need to detail out those processes more. So what do we do there? Well, now we're going to break down each of those steps and see what comes in between. And this really helps design your flowcharts. In our center, we design flowcharts for how every patient moves through our clinic with each discipline. And so what does nursing do? What does it look like from a nursing standpoint when a patient comes to clinic, and what are their roles? What does the respiratory therapist do? What do the physicians do? And how do they interplay? Key tips when you're doing these detailed process maps: use pencil, use sticky notes, use a whiteboard, something, because you're going to be moving this around and changing it a million times before you get it to where you really want it to look like. And these are some standardized shapes and things that are used in these. So circles usually mean the beginning or end of a process. A square is a step. A diamond is when you come to a decision point where you could have one path or another. And these clouds are sort of like, we're not quite sure what's going on here exactly. We need to come back to this, and that's okay. It's okay to have points as you go through that you say, we're not really sure how we want this. Put a cloud around it, know you need to come back to it. So when you're doing these, again, list your sort of primary activities under each step, and then start working through your drafts, share them out with other people, edit them accordingly, and they can help you find those areas where you need improvement. So here's an example of the more detailed process map, right? Somebody comes to clinic, we're trying to decide if they're eligible. The social worker or mental health care person reports that they're going to need screening. They add them to a board. They provide the screening form to the patient, okay? We've gotten this far. Well, now what happens? The patient has a choice, right? Either I complete it or I don't. So if they complete it, great. Then the screening is reviewed by the mental health care worker, and then they move forward in their documentation. If they don't complete it, what's going to happen then? Okay, the social worker is going to discuss with them why and ask them again to complete it. Again, we have a decision point. Either they complete it or they don't again, and then the social worker or mental health care person will help document their decision to decline screening and have further discussions verbally about their mental health to make sure that they're not missing anything. So this is how you sort of detail between those high-level steps to make a more detailed process map. And then you need to start thinking about, okay, we know what our process looks like, what are we really trying to accomplish? And we've talked about fishbones in other talks here, but the cause and effect diagram, or fishbone, is a really good tool for brainstorming ideas. And you think about here, you start with the causes of your issue. Why aren't we having better screening, right? We're only screening 50% of our patients. And so you start thinking about big categories of reasons why. People, for instance, are people burned out of doing too many questionnaires? And sort of list out from everybody all different things in these areas that then you can sort of build on and think about which ones do you think are most important to work on. So when you think about this, you, again, define your problem, put that at the head, and then you choose your categories, you brainstorm your ideas, and put them on the spines. And then they recommend when you take those ideas that you use what's called the 5 whys technique to get a deeper understanding. So you say people are burned out from answering questionnaires. Why? Well, because we give them 5 questionnaires. Why? Well, because we ask a mental health questionnaire now, but we also ask about food insecurity, and we also ask about their demographics, and we also ask about their anxiety. Why? And you keep digging to get to sort of that root cause of the why. And so for each of those problems, sometimes drilling down can help you come to something where you might be able to intervene. maybe we can break it down so that we only need a demographic screener once, we only need food insecurity every other time, and we can reduce those numbers. So it's a way to get to interventions that you might do by just digging a little deeper to get to that root cause. And then again, analyze, prioritize which things you think are going to be the most impactful, and importantly, what's feasible, right? If you say, people are unhappy with clinic because they wait too long, and your answer is, well, I'm just going to hire 5 new doctors, and that's not feasible, then don't work on that. Pick a different area to work on, right? And then develop, again, these solutions from those root causes. And so that's sort of how that fishbone can work for you. And then you come through and you put sort of all your different things in here and pick from those to help make that change that you want to see. So there's another way to do a similar type of exercise, and that's identifying and breaking down problems using a simplified failure modes and effects analysis. This is a systemized way of evaluating a process and understanding the ways it might fail, and then thinking about ways that you can correct that and intervene. And so the simplified version focuses on what are the potential failures, what are their effects, and then you brainstorm all the ways that you could potentially change these as well. So when you're constructing these, you sit down with your team. It usually takes a couple of meetings. You put your high-level process map in the center, and I'll show you a picture of this in a moment. Your high-level process map that we talked about earlier goes in the middle. And then you brainstorm all the things that could go wrong with each step, and you put those on the bottom. And then you go back and you re-brainstorm, thinking about ways that you could address those problems and either prevent, resolve, or address those failures. And this is how it looks. So you have your process map in the middle. They have their steps. We saw these before. Eligibility identified. Well, what are the possible failures? Well, we don't have any time to figure out who's eligible, or we didn't document it well enough so nobody knew, right? Okay, what can we do? We can develop a more efficient, streamlined way to identify people. We can track screening needs in a shared folder so everybody's aware. The patient is offered or receives the screening. Well, the patient can decline. That's one possibility. Here's another way it could fail. Nobody's available, nothing's available in their preferred language, or you run out of time in clinic. So what can we do? We can keep a folder with all the different languages available. So this is how you sort of go through and say, okay, what are all the things that could go wrong? How could we potentially fix that? And then you pick from these solutions to say, okay, I want to test this and this and this, and then these become cycles that you're going to work towards going forward. So it's a different way of doing a similar thing as the fishbone analysis. Once you have those things, you're going to want to know if a change is an improvement. So you set your aim. So your aim, right, answers the first question in the model for improvement: what are we trying to accomplish? It helps focus you. And when you're going to do a global aim, it's sort of your big picture goals, but then you really need your specific aim, and the goal is to really make it a SMART aim. And I know we talked about this the other day as well. It needs to be specific, it needs to be detailed. For whom? Where are you doing this? It needs to be measurable. So you have to do something that you can quantify in some way. If you do questionnaires, then you're going to be looking at the data, right? You have some data to calculate from. It needs to be achievable, so it has to be realistic, right? You can't do something that you know you have no ability to affect and do. And it needs to be relevant, right? It has to be something that's meaningful to the people in whom you're trying to work with. And it's time-based. Give yourself an identified deadline. We're going to do it from this time to this time. So here's a worksheet where you can use this. So you start with, we aim to, okay, increase the completion of mental health screening in our CF clinic from, well, our starting point. You need to know where you were starting from. From 50%, what's our goal? 85%. By when? December 1, 2024. So you put this together, for whom, okay, our target audience is people in the adult CF clinic due for screening at the time of our visit. So your full SMART aim becomes, we aim to increase the percentage of completed mental health screening for adults with CF in the whatever university CF's clinic from 50 to 85% by December 1st, 2024. So very clear, achievable, measurable aim with a timeline to it. And so this is really how I encourage you to set your goals when you do a project. So what change can you make that will result in improvement? So a key driver diagram is a way to have a visual picture of what you think derives or contributes to you reaching your aim. So you have to know an aim, that's again your SMART aim, and then you think about primary drivers. What are the main factors that directly influence you achieving this aim? And then secondary drivers are components that contribute to it, and change ideas are the specific actions or interventions that you might want to test to influence those things. So you create it by listing your global and SMART aim, and then you identify a few key drivers, again, these key factors, and then you think about prioritizing, listing potential change ideas and interventions that will go in another column, and you draw arrows from those interventions to which of those key drivers might be affected. You have an intervention and you can't find an arrow where it connects to a driver, you might want to rethink whether that's really an intervention that's worth doing at this time, because it's not going to help achieve your key goal. Start with, when you're trying to think about what key drivers should I have, if there's literature out there already, do a literature search. See if there are other people have identified some important factors that you can then apply to your own situation. If there isn't evidence there, talk as a team. What are the things that we think might be and might have had success here? What are high-level process failures that need to be fixed to achieve our aim? And think about those things together. So here's what a KDD looks like. So you have your global aim and your specific aim. We already went over the specific aim just a minute ago. It's a SMART aim. And then they thought about some key drivers for screening, right? Access to the necessary supportive screening tools, supplies, and resources, enough time in clinics to do screening, sufficient mental health care time to be able to accomplish these goals, and then clear communication and collaboration between our clinical goals in clinic. So then they started brainstorming things that they might be able to do as interventions. Well, they might be able to use a whiteboard to indicate which patients are due for screening, or they might complete mental health care visits after the provider to make sure that they have time to talk with the patient and get them to do this. They might keep paper copies of the screeners and pens in the clinic rooms so that they're readily available for patients when they have time while they're waiting. And then they sort of look, how do these drivers connect? Well, if we use a whiteboard, it might help us make sure we have access to things. It might also, they said, help their mental health people maybe need less time because it's going to be more organized. I would say they could have also drawn a line here because it will improve communication and collaboration. So that may be an easy, low-hanging thing that they can do, and they can test how it works. We use a whiteboard for a week in clinic. We say, hey, did we miss screening or not? Did we catch everybody? If yes, great, this works really well, let's keep that, right? If it doesn't work, we try to change the next thing, right? And so this is a really nice way to sort of follow yourself and make sure you can keep track of what interventions you might want to try, where you might want to go next, and how it might affect your different key drivers. So then what change can you make that will result in improvement? Well, this is where your PDSA cycles come in place, right? These are a small test of change. It's an opportunity to try an idea temporarily, minimizing risks, maximizing learning, right? And then you continuously adapt, adjust, or adopt these, or abandon them, right? So these should be really small cycles, quick things that you try, and if it works, great. If it doesn't work, are we going to change it or get rid of it, okay, and move on? And the failed cycles, when it doesn't work as intended, it's still a good learning opportunity to say, hey, is there something we can try differently, or is this just not really going to get us where we want to be? And so you can work through, this is just an example of a PDSA worksheet where they started with, again, what are you going to try to do? What's your objective? Make some predictions about what you'll learn if you do this change, right? What do you think is going to happen? Carry it out, and then look at what happened and talk about it from there. So they were going to use the whiteboard, they tried it, they thought it would remind everybody of what they need to do. So they tried it, and then they found that the whiteboard was helpful for the MA. If the social work prepped the whiteboard, it was easy to do. Other people, though, didn't know what it meant, right? So they used an X, and there was a fellow who came in and didn't know they were doing it, and the fellow thought an X meant it was already done. And so they came in and let the patient leave, even though the X was supposed to mean that, we're going in there today, that it needs to be done. So what happened? We looked at what happened and what can we change. And so they decided that there was enough good about this that they wanted to keep using it, but they needed to make a few changes. So they changed the symbols that they used, and they did more education for the rest of the team. So there are all these things, and as you come to the end, you decide, are we going to adapt it, make a change, which is what they did here? Are we going to adopt it? It's now working really well. We're going to keep this as part of our standard, or it just didn't do what we wanted. We're abandoning it. Let's move on to a different idea. Okay? And then you keep doing these PDSA cycles, and that's what becomes what we call a PDSA ramp. And so each cycle you make a change, then you decide if you're keeping it, great, you should move to the next idea. If you're adapting it, then you try that one, look at your results, and keep adapting until you get it working, or you abandon it and move on. And so when you put all these together, this is really a look at sort of progressing through from the beginning of a project, using all these tools to move through the steps to then, in an organized fashion, lead you through a project to its conclusion. And this is just an idea of where each of these tools fit, and there's a few others listed on here too. And I think that is what I had for you today. Thank you.
Thank you, Amy. I think we've tried to improve our standard here. Any questions? So bottom line is really we need action. So we need to have some QI work. We are here to support you. When we go back, we're not too far. We always can have Zoom meetings with you to walk you through the process. So this is introduction of the whole thing. Don't get overwhelmed. Just come up with an idea and talk to us, and we'll help walk you through it. Okay, Amy and I can work with you. We also have Kathy, our CF coordinator, CF center coordinator. We can all three of us meet with you guys and help you out. But it would be wonderful if we can start with just one project and move on. And that's what, again, I'm using the Turkish group, and it's okay now because the Turkish government and the Egyptian government are friends. I used to say it, and people like, don't talk. But yeah, so we really. So it's really important to not get overwhelmed, but start with one project and move on with it, and we'll help you through it. So that way, once you start it and you create the culture, everybody will be thinking the same way. That's what we started in the US. I started by basic training on quality improvement, then everybody started getting into it, and anytime there is something, they come to me and they say, we want to do a QI project on this. So it's creating the culture. So very, very important to move on with that.
السؤال معلش هو النيونيتال سكريننج ان ايجيبت هو دلوقتي 19 ديزيز فيها سيستيك فايبروزس
لا مش المشروع العام بتاع كل
19
في النيكيو بس هو apparently في النيكيو الستريس بتاع اي ديزيز in the neonatal period may affect ال IRT او ال screening results. Therefore it is not a good screen لل critical babies. It's a good
يعني
screen
المفروض
لل normal
تعمل all
babies.
the populations زي الهايبوثايروديزم زي
Yeah, it's a pilot project. I think now really the idea is to expand it to include all the babies. So, and that's when you're going to be able to identify the incidence of CF in Egypt. So I think they've been doing the pilot for the last 4 years, and now it's time to expand it. So I'm hoping that we'll reach out.
But I think in USA since a long time cystic fibrosis
2007. But there was only one state that did not join until 2010. But every state were ongoing since 2007.
طب regarding sensitivity and specificity how much يعني
It's a screening project. So you will miss some cases. So what we usually do, our algorithm is we do IRT, immune active carcinogen, and then we used to do 30 mutations became 60, and now we're doing 139 mutations. And then the next step is if that we actually do sequencing for the people with one mutation. That would come in within the next.
يعني any positive case by neonatal screening for genetic study after that.
لو البانل طلع فيه 1 mutation هيعملوا sequencing. لو طلع فيه 2 mutations هيعملوا sweat chloride testing.
Yes. And what we're doing right now is that if they have 1 or 2 mutations, they come to us, the center, we sweat them. And then for the 1 mutation, if it is borderline or not enough sweat, then we will do sequencing. If it's negative sweat, then we just say it's a carrier. So, and that again, I'll be happy to work with them. I worked with them in the pilot, but now we really need to expand it.
Okay, so I think we just break for a short coffee break.